At this time, I want to introduce Dr. Pardo, our director.
Thank you, Maureen, and thank you, everybody, for coming this morning to the Transverse Myelitis Symposium. As Maureen mentioned, it's extremely important for us to put all energy on this event, and particularly because transverse myelitis is not a problem for the patient. Transverse myelitis is a problem for the family. Transverse myelitis is a problem that is spread along many different areas. And what we like to do here is to work as a team to offer the best help and support that we may provide. The main focus of my lecture is to give you an idea about what is the meaning of transverse myelitis, what we do at the beginning when we are trying to understand transverse myelitis, and try to establish a diagnosis of transverse myelitis. Before we do that, I'd like to show this picture. This picture was taken this morning at 7:30. And guess who is the person who is here? So it's Maureen Milley pushing a cart full with stuff for the symposium. And that is exactly what Maureen does on a daily basis. She pushes us, okay, to work. So I basically need to acknowledge that the success of this symposium and the success of the Transverse Myelitis Center is because we have a lot of energy, and Maureen is helping us to focus the energy and to help patients with transverse myelitis anymore and patients with neurological problems. So thank you, Maureen. So I need to acknowledge the help of all our staff, all our colleagues, all our faculty. Again, this is a team effort. And when you come to Johns Hopkins and you come to the Johns Hopkins Transverse Myelitis Center, it's not necessarily the effort of the neurologist or the physician, it's the effort of the nurses, it's the effort of the therapists, occupational therapists, physical therapists, the effort of too many people that are behind the different walls of Johns Hopkins and the transverse myelitis trying to help and understand these issues. So this is what I like to achieve in the next 20 minutes. Number one, that you understand what means myelopathy and what means myelitis. I like that you understand what is the approach that we have about the diagnosis of transverse myelitis or myelopathies. And I like that you understand that this is an interesting situation in which we are finding new and new things related with myelitis. So when we do research, it's not because we want to establish a dogmatic concept. It's because we like to understand how things happen, and we like to understand exactly what is the best way to approach the problem and improve the situation with specific patients. It's very interesting because in the past 10 years, we are learning a lot about transverse myelitis. Patients that were diagnosed in the 80s and 90s, some of them actually were misdiagnosed with transverse myelitis. They didn't have transverse myelitis. They may have had other problems, and vice versa. Patients that were diagnosed as psychiatric problems or diagnosed with psychogenic problems, they had transverse myelitis, right? So we have been learning in a very good way what is going on in transverse myelitis. What do you do when you need to understand transverse myelitis? What's the first thing that you do? You go to Google and type spinal cord, or you go to Google and type transverse myelitis. What I'd like to explain to you is many of the problems associated with transverse myelitis originate in this important structure of the body that is called the spinal cord. The spinal cord is basically embedded in the spine, that is the bony compartment of our body. This spine is the full protection that this organ, the spinal cord, has to avoid any major damage or injury. And the spinal cord is comprised not only by structures associated with the nervous system, but it's also supplied by thousands of blood vessels is connected with the rest of the body with nerves that are going to communicate with arms and legs and other parts of the body. And all of this is part of a system that is extremely complex and involves basically the best function of the central nervous system. In 1999 and 2000, when we established the Transverse Myelitis Center for the first time, this was the view about transverse myelitis. Majority of patients diagnosed with transverse myelitis actually were labeled multiple sclerosis. And many patients erroneously got the diagnosis of multiple sclerosis and were treated as multiple sclerosis. And in 2000, many patients with transverse myelitis basically were in the basket of multiple sclerosis, demyelinating diseases. Many patients with diagnosis of Devick's disease actually were misdiagnosed as multiple sclerosis. What has been going on in the past 14 years is we have been learning more and more about the concept of what is transverse myelitis and what is myelitis. In 2010, in the first 10 years of this century, we have a lot of learning about transverse myelitis. For example, in 2004 and 2005, there was a lot of understanding of a disease that was called Devick's disease that affected the spinal cord and the optic nerves, and that disease had been also called neuromyelitis optica. And at this moment in 2005, this disease actually was redefined because researchers around the country found that this disease is produced by an autoimmune disorder in which one antibody produced by our immune system is attacking specifically the spinal cord. Dr. Levy is going to discuss about that issue later, but this has been one of the most important advances in understanding myelitis in the last decade, because this allows us to identify patients that may be treated. And there are a lot of specific treatments for neuromyelitis optica as compared with multiple sclerosis or other neurological disorders. So this has been one of the most important advances in the last 10 years of research on myelitis. Interestingly, the concept of transverse myelitis is basically leaving the sphere of influence of multiple sclerosis. And this is another important advance, because we understand that patients with transverse myelitis or myelitis are different to multiple sclerosis, and they need to be treated in a different way. These patients are not going to benefit from the medication that we use in multiple sclerosis, and many of these patients actually need to be evaluated carefully because there are many aspects of the biology of this disease in which we are able to intervene and treat the disorder. We still have a lot of concerns about infection, and we understand that some infectious process may trigger immunological disorders that may produce abnormalities in the brain or the spinal cord. Is something that is called acute disseminated encephalomyelitis. This is still a major issue because particularly children may be affected by viral diseases, respiratory problems, gastrointestinal problems, and the immune system subsequently develops an immunological attack against part of the central nervous system that may include the spinal cord and eventually may produce inflammation of the spinal cord. We have also a constellation of rheumatological problems that may affect the spinal cord. We have disorders like lupus, we have disorders like psoriasis, we have disorders like sarcoidosis that eventually may produce a selective damage of the spinal cord that occasionally is identified as myelitis or myelopathy. So as you can see, in more than 10 years, there has been a lot of understanding of the concept of transverse myelitis. Today, in 2014, we are paying now more attention to disorders that we ignore completely. For example, neuromyelitis optica is now part of a complex of disorders that may affect the spinal cord and the optic nerve. We have a much better understanding, and we are paying a lot of attention about vascular myelopathies. And this is an issue that I like to emphasize because at the beginning, some patients may be misdiagnosed as transverse myelitis when they are having a stroke of the spinal cord. This is not frequent fortunately, but this is a condition that may affect children and may affect young adults and elderly patients. But this is a condition that in many ways may be diagnosed and occasionally may be treated specifically to avoid the damage of the spinal cord produced by vascular problems. Now, it's very likely that children with transverse myelitis may have a different spectrum of diseases. I mentioned before that acute disseminated encephalomyelitis is particularly a problem in children, and this is because they are more exposed to infectious disorder, viral infections that trigger immunological reactions against the brain and spinal cord. And again, one of the issues in this population is that they are exposed to all sort of challenges, including infections, including vascular myelopathies, and including other type of disorders that may affect the spinal cord. So when we are dealing with children with transverse myelitis, we are very careful now to do a very thorough assessment and make sure that they don't have neuromyelitis optica or they don't have any of the other immunological mediated disorders. It's very likely that in 6 or 10 years, the spectrum of transverse myelitis is going to be completely different. It's very possible that we may have different type of diagnosis. Now, just to emphasize in the function of the spinal cord, as you know, the spinal cord, I always call the spinal cord the I-95 of our body, because the spinal cord is communicating our brain with the rest of the body, and there are lanes going up and lanes going down, and this is extremely important for function. So the function that we have in the spinal cord is divided in different systems. It's divided in the motor system. This is when the brain is generating orders that need to go to the arms or legs for movement, and they need to cross part of the brain and part of the spinal cord to end up in our muscles. So the sensory function is extremely important because this is the function in which part of our skin or receptors in the rest of our body are sending information to the brain, or information associated with autonomic function like bladder function or bowel movement function that is determined by the good communication that the spinal cord may have with the brain and the other part of the organ. So as you can see, that is the reason I-95 of our body is critical for communication. If there is a disruption of that communication, the dysfunction of different systems is going to be very prominent, and we may end up with motor symptoms, sensory symptoms, and autonomic dysfunction. And that is very well mapped in the spinal cord, and that's the reason when we do analysis, clinical examination, or MRI assessment, we try to understand in which part of the spinal cord the lesion is affecting. And that's the reason when you are coming to any clinician, when you are coming to any neurologist or therapist, they are emphasizing in the role of motor function in the assessment of sensory function and the assessment of bladder and bowel movement. So when you come to the neurologist, we pay attention to different issues, and the most important issues in our analysis is to understand, number one, is what has been the evolution of the symptoms, where is the location of the problem, what type of problems we may have based on analysis of the MRI or spinal fluid analysis, and now based on a spinal angiogram. So all of this is part of a very comprehensive assessment that needs to be done at the beginning of the disease. So when you are going to the neurologist or physician or any health provider is obligated to ask you a detailed clinical history about what is the evolution of all of these symptoms, how everything started. And this is going to give us a very good idea about causes of the myelitis or myelopathy, and also to identify potential issues that we are able to treat. So again, this is fundamental for understanding what is going on at the beginning or during the stage of development of transverse myelitis or any type of myelopathy. So the first rule that we have is establish the right diagnosis and make sure that we are dealing with the right disorder. Because if we are dealing with myelitis, we need to understand that myelitis is a disorder in which the spinal cord is inflamed. And if we are dealing with other problems like vascular myelopathies, we need to understand why a patient is having a vascular myelopathy or a blood vessel occlusion in the spinal cord. The same has happened with our heart that is exposed to ischemia or blockage of arteries or veins. The same may happen with the spinal cord. That's the reason we are emphasizing in the past few years about a better understanding of patients with vascular myelopathies versus inflammatory myelopathy. So the basic concept is inflammation of the spinal cord means myelitis, and damage of blood vessels that lead to problems in the spinal cord is called vascular myelopathy. So that's the distinction that we are emphasizing to our colleagues and physicians to pay attention. Now, the temporal profile of problems is helping us to establish a very good diagnosis, and I always talk about the equation for diagnosis of myelopathy. And the equation involves analysis of the pattern of weakness, motor dysfunction, the pattern of sensory problems, the difficulties with gait or abnormalities associated with bladder or bowel movement dysfunction. And accounting for those patterns, we need to establish a very good timing or temporal profile of the problem. So in that way, we are able to achieve a very good and reliable diagnosis that allow us to treat with the best therapies that we have available. Let me give you an example. There are myelitis that behave as a relapsing remitting form of myelitis. Those myelitis are probably associated with demyelinating disorders or even maybe associated with disorders like neuromyelitis optica. But there are myelitis that happen only once and produce a very aggressive damage of the spinal cord, and those are the typical strokes of the spinal cord that leave patients with a lot of disability. So that's the reason when we are analyzing the temporal profile of patients, we pay a lot of attention about the beginning of the disease and how the symptoms evolve in terms of hours, days, or weeks. I'm running out of time, but I want to emphasize that the analysis that we do is important because that allows us to establish the proper treatment. If we have a patient with an inflammatory myelopathy that is either related with some immunological disorder or a post-infectious disorder, obviously there are very good ways to treat the problem, like use of prednisone or IV steroids, use of plasma exchange immunosuppressive medication. But as you can see, the other spectrum of the coin is that there are patients that do not have inflammation in the spinal cord. They may have vascular problems, and those patients are not going to benefit from these therapies. So that's the reason establishing a very good diagnosis at the beginning is the best pathway to recovery. Because if we made that wrong diagnosis, obviously we establish the wrong treatment, and that is going to be difficult. Maureen already showed this slide, but this is to emphasize that in the spectrum of differential diagnosis of transient myelitis, based on research that she took with the patients that we have seen at the Transverse Myelitis Center in the past several years, so a third of the patients approximately have been misdiagnosed with transient myelitis. So we need to make all effort to establish the proper diagnosis to find the best treatment. Again, I need to mention that this is a team effort because we are in the World Cup. I need to bring a balloon here, a ball, and I need to tell you that my team, Colombia, is doing very well. Thank you very much.
We have a couple of minutes for just a couple of questions. And I'm going to give Wendy the microphone so that she can hand it around. Any questions?
I'm kind of confused on the plasma exchange therapy. I originally understood that people with transverse myelitis needed to be treated with it almost immediately. Then I read where people have had it much later on. When is plasma exchange usually used?
So in inflammatory myelopathies, plasma exchange is very helpful if that inflammation is associated with presence of what we call antibodies or autoantibodies. Let me give you an example. In the case of neuromyelitis optica, the main damage in the spinal cord is triggered by an antibody that the immune system is producing in an excessive amount. And by doing plasma exchange, we are getting rid of that antibody, and obviously that is going to decrease the amount of injury in the spinal cord. The problem is, as I mentioned before, is not everybody who is diagnosed with transient myelitis is a candidate for plasma exchange right away. And the reason is until the clinician is not very sure that he's dealing with an inflammatory myelopathy, it's very risky to expose a patient with a myelopathy to plasma exchange until there is not a good diagnosis. The reason is we are seeing a small group of patients, and fortunately it's a small group of patients in which there is a diagnosis of a venous abnormality, venous vascular problems of the spinal cord, or even a stroke of the spinal cord that rush to be on plasma exchange, and that is a major problem because plasma exchange is basically consists in taking blood from the human body and cleaning and getting rid of the immunoglobulins. The problem is by doing that, we are decreasing blood pressure that is extremely valuable for keeping the perfusion of the spinal cord. So not everybody is a candidate for plasma exchange. So when a patient is evolving very quickly in the process of myelitis, a patient gets paralyzed in a matter of 1 hour, in many ways, I will say I am not keen in putting that patient in plasma exchange. The reason is because that acute event may have been associated not necessarily with an inflammation, but rather with a vascular problem.
Thank you.
Good morning. Is there difficulty in establishing between the two, whether it's a vascular or an inflammatory cause?
So we have advantages of imaging of the spinal cord. Magnetic resonance imaging of the spinal cord is very helpful to raise a very good level of suspicion for vascular myelopathies. When the MRI of the spinal cord, for example, when it's done properly with gadolinium enhancement, if the lesion is there, but there is no enhancement during the first part of the myelopathic process, that is very suspicious that the process is not associated with inflammation. The spinal fluid analysis may provide also a very good idea if there is inflammation, there is not. So the clinical assessment of the patient is very helpful for understanding if there is a vascular problem or not. So we always say patients that evolve very quickly in matter of 1 hour or 2 hours that we call hyperacute evolution of symptoms, and they are paralyzed in matter of 2 hours. Those are patients in which we need to investigate very carefully the possibility that that is a vascular damage. On the other side of the coin, patients that have chronic evolving myelopathies in which there is not too much evidence of inflammation, those are also patients that may fit in a diagnosis of potential venous thrombosis or vascular problems. So is difficult sometimes, but we have better tools right now like MRIs, spinal fluid analysis, and in third-level hospital, tertiary hospital like Johns Hopkins, we have access to a spinal angiogram. That is a technology that allows us to analyze the blood vessels that are supplying the spinal cord.
Good morning. In terms of the figuring out the pathway, like patient shows up in the ER and seen by a neurologist, what kind of timing, and if they showed up with the acute paralysis that occurred as you're describing?
So we are trying to emphasize to our neurology residents, clinicians, all type of students in training that a patient with acute onset of spinal cord dysfunction is an emergency. So the time profiling here for your assessment is the same that a person with chest pain or on a stroke should have. The problem is, as compared with cardiac attacks, chest pain, or strokes, the knowledge in the ER and the knowledge that the community physicians have about transient myelitis is really minimal. So we are trying, by doing the same type of symposium with physicians, we are trying to educate our colleagues in the understanding of transient myelitis so they can approach the patient in the way that we like that the patient need to be approached. So this is basically an emergency. Right. There are situations in which the symptoms, sensory symptoms, have been evolving for 3 or 4 weeks or months, and obviously that means that there is not necessarily an emergency, but if the evolution of symptoms is happening in a matter of hours, and there is disability, motor dysfunction, sensory problems, and bladder dysfunction, that need to be considered to be an emergency.
There was one last question in the back.
Yeah, my question was with regard to success level use of cancer medications. I know there was a trial period there where cancer meds were being used. My brother lives in Miami, and that's where he suffers with TM. They used it on him, and we're trying to see how well that is. I just wanted to know what the success rate of that type of thing.
So one of the problems that we have in transient myelitis is the diagnosis of transient myelitis is very difficult in some settings, and at this moment we haven't had a very serious clinical trial to test those medications. We use these medications, plasma exchange, immunosuppressive medication, or IVIG, empirically, meaning that we believe, based on our experience and anecdotal experience, that those are effective, but the truth is, as compared with other disorders like hypertension or even cancer, we haven't had serious clinical trials that answer that question. So the answer is we think that they may help because there is inflammation, but there is no real proof for that. Dr. Levy is leading an effort here to do research in neuromyelitis optica, and he's leading efforts to do clinical trials in neuromyelitis optica. And at the national level, there is some effort in pediatric TM in which we are participating to prove if plasma exchange versus IVIG is effective in the treatment of children with transient myelitis. But at this moment, there is no real clinical trial that proves efficacy or no efficacy of the medication that we have for transient myelitis.